同事，咁歡迎大家嚟到我哋呢個 Child Sim Talk。咁有咩好可以講咧？其實今日咧好重要嘅，因為咧我覺得 signify 幾樣嘢。有啲病咧，我哋近時以為咧就即係醫唔到嘅，幫唔到嘅。咁原來咧慢慢又有啲方法。咁當然第一就靠 science 啦，第二咧都要靠啲 politics 嘅。咁大家都記得呢個畫面啊，就係咧呢個圖畫咧就係令到好似冇得醫嘅一個病咧，有啲希望咁樣。咁跟住就大家見到呢啲畫面啦。咁所以咧就SMA 呢樣嘢咧，其實就除咗喺 medical 嘅 domain 大家留意到之外咧，喺我哋政治上面咧都見到即係有個 effect。咁都有人同我講過，佢話無論你做得幾辛苦都好啦，其實policy overlay 先係最重要。咁咧呢件事上咧就見到啦，即係我哋可能幾倍人去努力都未必解決到個問題，但係有時咧 politics 咧又可以解決，一啲政策又可以解決。咁我唔應該講 politics 又唔應該政策嘅，咁所以咧今日咧我就將個時間咧交俾阿楊偉蘭醫生。咁好開心啊，因為我頭先我哋同一個醫院做嘢，我好少撞到佢。咁佢頭先佢講翻啲往事咧，佢就話我嗰時介紹佢去呢個 Vancouver 度 training。咁好在都好似冇講錯嘢咁啊，都啱嘅。原來 Vancouver training 啱。咁佢又幫我哋即係 set up 咗我哋嘅 EDU 啦咁樣。咁咧就今日我將個時間交俾阿慧蘭，等佢哋咧就介紹我哋今日嘅講者同埋我哋今日嘅題目。
大家好，歡迎參加香港兒童醫院舉辦嘅 Child Sim Talk 啦。咁我好榮幸啦，今日可以介紹今集嘅 speaker Dr. Sophelia Chan。Dr. Chan 咧係香港大學李嘉誠醫學院兒科嘅 Clinical Assistant Professor， 亦都係兒童腦科嘅專科醫生。咁佢咧就特別專長於咧診斷同埋咧醫治嗰啲神經肌肉病嘅病人嘅。咁佢今日嘅topic 咧就係 Current Advancement in the Management of Spinal Muscular Atrophy。咁好似頭先 Dr. Bill Chan 講啦，我諗好多兒科醫生咧都曾經咧係親自目睹過咧嗰啲 SMA patient， 特別係 Type 1、Type 2嗰啲 patient 咧，佢哋個病情咧係每況愈下嘅。即係除咗佢四肢無力之外咧，慢慢咧佢哋連呢啲吞咽啊，或者係呼吸啊，甚至乎係脊柱側彎嘅情況咧，嗰啲 complication 一個一個咁出現，其實係好無奈同埋即係好心痛嘅。作為兒科醫生，咁咧今日咧我哋就大家都好期望、好期待咧聽聽陳醫生咧為我哋詳細講解關於咧治療 SMA 最新嘅發展。咁我將呢個時間交俾Dr. Chan。
Thank you。咁好多謝Dr. Bill Chan 嗰個 invitation， 我覺得好honor 可以有呢個機會喺 Sim Talk 嗰度可以 share。呢個 experience 同埋呢一個係一個團隊嘅 effort 啦，亦都好多謝阿楊醫生頭先嗰個 introduction。咁其實我識咗楊醫生都好多年㗎啦，咁我哋係好朋友，亦都有好多互相嘅consultation。咁佢就係喺兒童pediatric epilepsy 嗰個專家啦。咁今日咧我頭先都傾過，因為講個 topic， 希望大家都容許我咧開始講嘅時候咧用英文，因為我曾經嘗試過用中文去講咧，一翻譯啲中文嗰啲嘅學名咧就實在係會好甩咳嘅。咁為咗可以好流暢咁樣去分享翻即係過往好多個團隊一齊合作嘅經驗咧，咁我希望大家都唔好介意我用英文去講吓。So, can start. So, today actually I separate my topics into a few major sessions. And I think most important is for many of you who actually know what is SMA, please spare with me some time. But for those of you who actually know a bit but not in detail about this group of children, I hope take this opportunity to share with you what is the problem? What are they having? So SMA is actually a condition, a neuromuscular disease caused by an underlying genetic mutation. The mutation occurs in the SMN1 gene, which is on the chromosome 5. You can see that there are actually two SMN genes. One is called the SMN1 and the other is called the SMN2. Those patients with a mutation of the two SMN1 genes will have problems with the transcriptions. So the messenger RNA, because of the exon 7 skipping, will miss the exon 7 and leading to the problem with translation and making the functional protein, the SMN protein, cannot be produced. But on the other hand, every one of us has the SMN2 gene. SMN2 gene is like the brother and sister of SMN1. So there is only one. They are actually identical almost, except that there is the complementary position as DNA position in the 840 from the C to T that cause there is an alternate splicing. The alternate splicing means sometimes they will have full transcriptions of these SMN2. So you will have all the exons being transcribed and then translate into SMN protein. But majority of them will skip the SMN7, the exon 7. So again, you will see those who have the SMN2, the higher the number, the higher the percentage of the SMN protein that they will have. In fact, this actually is reflected from the previous unnumbered clinical study who showed that the number of SMN2 copy actually correlate with the severity of the SMA type. So you see patients with SMA type 1, actually majority of them has 2 copy of SMN2. Some of them has 1 copy and some of them has 3 copy. In contrast with the milder SMA type 2, majority of them has 3 copy of SMN2, while some of them has 2 copy to 4 copy of SMN2. For the milder type, which we call them the Walker, SM8 type 3, actually majority of them has 3 to 4 copy of SMN2 gene. Why I'm especially highlighting this slide, this is because not only that it is important to know the SMN2 copy number, but at the same time, after knowing it, nowadays the treatment actually is add on this SMN2 gene that bring on the clinical effect. So the higher the number of the SMN2 copies, it actually the milder the disease phenotype. So majority of our patient with SMA actually has homozygous SMN1 gene mutation with the exon 7 deletion. Some of them has exon 7 and exon 8 deletion. Only a very small percentage of patient has compound heterozygous. Why I want to highlight that? Because the patient actually has only one exon 7 deletion of the SMN1 gene, while they will have another small mutation in the SMN1 gene. So if we do the method just to test the exon deletion of this patient and without doing the sequencing analysis, we may miss the diagnosis of this small percentage of patients with SMA. We know that this is an autosomal recessive disease, so 25% chance for the child of the carrier parents will actually get SMA, while 50% chance of the children will be the obligate carrier like the parents, and 25% chance the child will be totally unaffected without the gene being involved. This is the classical classification of the different type of SMA. So we all know the Wernicke-Hoffmann disease, which is the type 1, and this actually are the most severe disease and have the onset of less than 6 months age. They have poor head control, they cannot sit, and they have problem rolling over. Without ventilator support, without feeding support, majority of them actually die before the age of 2. And in fact, they account for the highest number of the SMA patient. For the SMA type 2, we call them the sitter. They're able to sit on their own, and they have a slightly later onset after 6 months, but before 1.5 years old, and they can survive to adulthood with support. And 1/3 of the SMA actually is the SMA type 2. While the milder SMA type 3, we call them the Cougar verulenta because of the doctors who discovered them, have the onset after 1.5 years of age. They can be as late as adolescent age or as early as during the early childhood age. They are able to walk, and most of them has normal lifespan, and they account about 15% of the SMA. I have to say that all of these children, with time, they deteriorate. So for SMA type 2, they will lose the ability to sit when they get older. And for SMA type 3, half of them actually lost the ability to walk when they enter adolescent age. Only 1% of patients present in their adulthood, and we call them the adult onset SMA, or some of them will actually need to use the walking aid when they get into the elderly age. So SMA is actually a medically complex condition that deteriorates over time. These are the patients from very early onset, from a few months old that are already with feeding problem that needs tube feeding with paradoxical breathing, to later in age that actually is totally medically dependent, that need 24 hours ventilator and full gastrostomy feeding, and fully dependent in activity of daily living. SMA type 2, they actually are a sitter. They are able to sit well, but as time grows, like this child, eventually they actually get weaker in the upper limb, and the trunk get weaker, and they have progressive scoliosis. Like SMA type 3 of this child, they can walk around at young age, but when they enter the adolescent age, they have difficulty in getting up from sitting, and eventually will lose the ambulation. How common is SMA? All type of SMA is about 1 to 2 per 100,000 persons. So for SMA type 1, we're talking about 4 to 8. And SMA type 2 and 3, we're talking about 1.5 per 100,000 person. So estimating the incident is about 1 to 6,000 to 1 to 10,000 live birth. We will estimate around 5 or 4 to 8 children with new SMA being diagnosed each year. The carrier frequency in Asia and in Chinese is around 1/40 to 1/60. So what is the natural history of SMA? As we all know, SMA type 1, majority of the patients by the previous study actually die before the age of 2. And you can see that with the use of ventilator, actually the survival improve. And those with 3 copies of SMN2 actually has a better survival than those with 2 copies of SMN2. This is a child actually was born normal at birth, and she was totally unremarkable antenatal history, and you can see she has a lovely face. And only at the age of 1 year, 6 months, you can see the significant deterioration. He actually needs to put on NIV and needs a gastrostomy feeding, and with a bell-shaped chest. I'm sure many of you who actually has patient with SMA type 1 will be familiar with this type of natural history. For SMA type 2, even though they are milder, we call them the sitter. I know this little girl, she has a lovely face when she came to my clinic at the age of 3. But over the subsequent 2 to 3 years, she has marked deterioration of her scoliosis. So you can see that how significant the curve affecting her sitting. The brace help her to be able to sit more upright. Following the standard of care, she's actually helped by our physiotherapist to do some hydrotherapy, to do some upper limb exercise, as well as some breathing exercise for the for the respiratory muscles training. At the same time, she has an electrical wheelchair so that she can actually move around. This is her actually soon after we have taken the earlier photos. You can see the marked scoliosis actually make her compressing not only on the lung, but make her sitting balance very bad. Our surgeons actually gave her a growing rods, put in a growing rods that helped to improve the sitting posture a lot, and with the help of the occupational therapist that improve the alignment using the special chair. You can see it actually helps to improve the sitting posture a lot. Here is a pressure map of the seating that is actually provided by the occupational therapist. You can see those red color actually is those of highest pressure on the buttock. But with the scoliosis surgery, insertion of the growing rods, and also with the special chair, you can see that the high pressure disappeared. So I want to highlight with these slides because standard of care is very, very important, and multi-specialty support to take care of this group of patients that is medically complex is also very, very important. This is my other patient that came to see me because of motor completeness at the age of 3. You can see a bit of wetling already at the age of 3 when he was walking. He could walk fast. And mother said he actually, when he walks fast, he tends to fall easily. And this is him when he tried to get up at the age of 3. Again, you see a bit of motor clumsiness, but she can actually get up all on his own. But you see it's different when he is almost 10 years old, and it is really difficult for him to get up, and he has to crawl himself up, pulling, lying on the bed and getting the support of the bed. And when he was 12, he actually could no longer be able to do so. So again, these are not rare story, but actually it occurred commonly in our patient before the era of treatment. I love this slide because with the new treatment for the SMA, actually we see there is a change of disease course, and we see hope for this group of patients. Let me tell you, everything happened with history. And I guess the most important thing is without those dedicated doctors, and they're really a talent doctor who find out this SMA group of patients 100 years ago, we would not be able to have the discovery of the genes in 1995. And only with the discovery of the genes that I have to say the genetic diagnosis is actually one of the most important milestones for all the disease. Then we started to have the standard of care, knowing the classification, and even to have the preclinical study starting with the animal models. With the starting of the animal models, in fact, a number of preclinical studies using different investigatory drugs that I would further explain later, leading to the clinical trial. And up till now, we already have 3 FDA-approved treatment for SMA. Hong Kong actually joined the clinical trial for one of the treatment, the nusinersen, in 2015. And after that, in 2018, actually we started the extended access program for those patients with SMA type 1, and followed by 2019 for all the patients with SMA type 1 and type 2 and type 3 that fulfill the inclusion criteria for treatment with the nusinersen. I guess this is very exciting to know because these are very expensive drugs, and we really want to know, are they helping our patient? Just last year in August, we also have the new SMN2 splicing modified oral drug that is being approved. And earlier in 2019, there is actually the SMN1 gene therapy is also approved, but these are not available in Hong Kong. So taking this slide, I can help me to simply explain to you what are all this treatment is about. This is actually the gene therapy is using the AAV vector that carry the SMN1 gene into the body. So these can be given by intravenously, so it can circulate around the body and also going to the central nervous system. The nusinersen act on another mechanism, which is the SMN2 gene that I have explained. And in fact, there are two drugs that add on this SMN2 gene that modify the splicing and then lead to increase of the SMN protein. One is the nusinersen that needs to be given intrathecally. So what we mean is we have to do a lumbar puncture and inject the drug through the lumbar punctures. The other drug is called the Ristablan. This can be given orally. These are the three FDA-approved drugs, but the story never ends there because there are still ongoing clinical trials on the downstream pathway helping to find the better ways to improve the clinical outcomes for this group of children. A number of clinical trials has been carried out, and the most famous is the ENDEAR and the NURTURE study. One of the common points is all these group of children are started the nusinersen treatment before 6 months old. You can see the different colors that is being highlighted actually signifying the different group cohort of patients. This is called the Heine-2 scale. The Heine-2 scale actually measure the milestones gained of our patient. The maximum score is 26, means the patient not only be able to walk, not only be able to sit, to kick, to crawl, to stand, but also to walk. You will be amazed to see one group of the patient actually has full score along the times with the continuation of treatment. And in fact, these are the group of patients with the having the treatment under the NURTURE study to the pre-symptomatic SMA patient, means they are identified by the newborn screening and then have the treatment started at the pre-symptomatic stage that actually make this group of children almost like normal. The other group also do very well, but slightly less than the green group because they have 2 SMN2 copies. So they are also good because they start at the pre-symptomatic stage, but because they have less SMN2 copy, they are not doing as well as the free SMN2 copy group. How about these other group that we are seeing? The orange color and also the gray color are actually the shammed group, means that they receive the treatment, so they eventually deteriorate. And these are the group right at the beginning be able to continue with the treatment, but before they are all started treatment at the symptomatic age, and they all have 2 SMN2 copy. So you can see that the ongoing improvement is being observed with the continuation of treatment. So all this group of children actually start early, before 6 months old, but the earlier, the better is clearly highlighted with this graph. And in fact, the NURTURE study, after following up this group of patients more than 2 years of treatment, 100% of them achieve independent sitting and 88% achieve independent walking. And I think this is amazing. In the old days, who would have imagined that this can happen? The CHERISH study is about the nusinersen versus SAM control in the late onset of SMA. The late onset means type 2, and they are between the age of 2 to 12 years old. And then they are able to sit independently and can be using NIV or IV, but not more than 6 hours per day. And they can have scoliosis, but not significant, and must be less than 40 degrees. And they cannot rely on gastric tube for feeding. So you can see that they are choosing the group with milder severity and actually as clinically more stable. You can see here the Hammersmith Functional Motor Scale. I'm sure the physiotherapists will know this test very well. And the revised upper limb modules again. Those in blue are undergoing the nusinersen treatment. and those in gray are actually the control group. You already can see the marked difference between the two groups in the performance of the whole body motor gain and also the upper limb strength and function. There is another publication in New England Journal of Medicine on the single-dose gene therapy. They only gave the treatment to 12 patients, and then they gave the FDA approval. Again, most of the patient has the treatment before 6, but I have to say majority actually has the treatment before 3, and some as in the pre-symptomatic stage. This is the low-dose group, which actually do not have very high score. The score they are measuring is CHOP intent. Again, the physiotherapists will know this scale very well. CHOP intent has the maximum score of 64. They measure all the small muscle gain very detailedly. So they can detect any improvement in the muscles and the motor performance, even in the distal muscle group. And you can see those with a high dose group actually has very good clinical performance with significant gain in a CHOP intent score. And actually a number of them can be able to achieve sitting and walking. This is a summary slide telling us what is going on. The free FDA approved drug is highlighted here. Nusinersen is already available to our patient in Hong Kong, and we already started the treatment program in 2018, and thanks to the support of our government. And I agreed, as Dr. Chan mentioned, the policy support is very important, and that makes the team actually has the support to provide the necessary care for this group of patients. You can see wristband, which is actually given orally after approval, and I know that they have already come to Hong Kong and approached the HAHO. So very soon they will also be available to our patient to give another alternative option for our patient. For the gene therapy, they only approve for the pediatric patient less than 2 years of age. And I guess this is something we need to explore and get to know more about this. So with the availability of the treatment, what are the changes we observe after our patient received the drug? Firstly, we must highlight that these are expensive drugs, and that's why this group of patients must have good compliance to the recommended standard of care. And these involve the multi-specialty and multidisciplinary team engagement and participation, and sharing of experience are very important. We follow the standard of care guideline, latest published in the 2018. This is because with the availability of the treatment, we found that actually we see a new phenotype of the group of patients, because like the Sma Type 1, some of them will no longer require the use of ventilator even at a later age. Or some of them even actually started to have standing exercise. And what happened to the hip and the joint and the lower limb joint care? So again, a lot of new questions arise that we need to learn from this group of patients. The new standard of care aspect not only involve early diagnosis with the genetic confirmation, not only include the physical therapy and rehabilitation care and orthopedic management, but it also highlights the importance of the pulmonary care and the acute care when they get sick in the hospital setting. Nutrition, growth, and bone health are getting more and more attention, as well as other organ involvement. Drug treatment is a new area. Whether in the future it will be a combination of treatment, we do not know. And this is a new area that people are exploring. And again, palliative and ethics is also important, because not all patients will, have the same clinical response after the treatment. And some of these patients actually are already at a very advanced disease stage. So even with the availability of treatment, there may not be a significant big changes to the clinical motor performance. This is the multidisciplinary team that is involved. It involved not only a big group of specialists, but also, majority of the airline health professional. I have to say our SMA treatment nurse coordinator are actually the heart of this program because he's helping make the best connection between the specialty professionals team together with the airline health team connecting with the family. All patients will be followed up every 4 to 6 months, either in the regional hospital, following the standard of care. We actually think the shared care model is very important. Even though the treatment will be carried out and centralized in a treatment institute, this sharing of standard of care with all the hospital that is originally taking care of this group of patients, in fact, is most important because they are close to their home, they're familiar with the family team. So whenever they have anything that goes wrong, it is best for them to go back to the family team to take care, and we always get communicated. And we, in fact, have a meeting in the HAHO to make sure that all our patient has good compliance and everyone is following the standard of care guideline. So up till now, we have over 20 patients receiving treatment. We have SMA type 1, we have SMA type 2, we have SMA type 3 patient. Majority of our patient is actually SMA type 1 and type 2. For the type 1 patient, they are very fragile. I have to say we have one patient actually refused treatment because the patient is already in a very, very advanced disease state. And then after counseling, the parents actually opt for comfort care for the child. We also have patients pass away while waiting for the treatment because they are so fragile, and any minor illness or any minor adjustment actually will tilt the balance of their health. Recently, our team carried out a health-related quality of life study for some of our families and patients who received 1 year of nusinersen treatment. So we all know that SMA is a complex medical condition that requires frequent hospitalization. So we would expect the quality of life of the patient and the caregiver is low and is very stressful for the families with heavy burden taking care of them. So in May 2018 to September, we have 19 patients started nusinersen. Up till now, we have a few more patients also started on nusinersen. But at that time, we have 13 patients who actually complete 1 year of treatment. So we have SMA type 1 patient, we have SMA type 2 patient, and also one SMA type 3 patient. Some of them are on NIV and also gastrostomy feeding. More is in the SMA type 1 patient. The mean age is 7.2 years. We measure the quality of life by the Essence scale, which is actually a questionnaire to assess caregiver experience and burden taking care of this group of patients. So we will ask them what is the burden when taking care of the child's feeding, grooming, dressings, transfer, and mobility. And in general, how are they feeling emotionally? Any problems with their time management and finance problem? We also use the PITS-QL family impact modules to measure the family functioning, whether there is any impact on the social functioning, communication functioning, family daily activities, and even family relationship. We also measure the PITS-QL's child's health-related quality of life by parents' report questionnaire. We also use the patient questionnaire, but because only a few of them actually in the adolescent age, so we have a small number of that being reported, so it's not reported here. Last, we have a self-report questionnaire that actually asks them to report their perceived change after treatment. You can see from this slide the questionnaire score. We have 7 patients with SMA type 1, and we have another 6 patients with SMA type 2 and 3. Those in up arrow in red are actually improvement. So majority of the patients actually find less burden in taking care of the child's daily activity. The family functioning is getting better, and the child, they perceive, the parent, the quality of life is improved. However, we also see some scored less as compared with the start. And there are actually other reasons for that. When we actually take a look, like this patient, the adverse family event can actually affect, the family impact. Actually, the family recently the parents divorced. That makes the parents in extreme stress at that time. And again, like some children, because of the social reason, cannot attend school. And again, the parents, when being asked about the social relationship with peers, they realize that with more stable health, actually the quality of life with the friends is not adequate. We also correlate the motor score of this group of patients. You can see some of them improve for the SMA type 1 using the Heine tool, CHOP intent, and the revised upper limb module, but some of them is unchanged. And again, with the SMA type 2 and 3, we can see even though most of them has improved in the score, some of them which is quite severe to start with and actually has unchanged in the motor score. So how about the self-report changes? And in fact, all 13 patients reported improvement in the motor function. And 11 out of 13 think the upper limb is improved, and equal number think the lower limb is improved. Also, a high percentage of patients in type 1 reported reduced dependency on the ventilator. And half of those that require gastrostomy reported less choking, can eat more food and also more variety. And there is also other reported improvement like speak louder, speak clearer, and being able to recover faster from sickness and feeling invigorated and has improved attitude towards exercise. These are some of the words that is being written by the family. And then this is what it said, 總括來說，小朋友用咗藥之後，身體機能、抵抗力咧，同埋耐力都進步咗。最重要嘅就係佢個生活質素咧 ，quality of life，從而得到自信同埋肯定。佢可以對未來充滿希望，對於身心發展都有大嘅幫助。So I think this is a bit vague, but this is positive. And you can see here when he said 以往入醫院 PICU 每次要住2至3個星期先至康復，而家啱啱都中咗甲型流感，但係咧康復得好快，留院唔夠1個星期就可以康復出院。So these are the actual things and life experience that makes the family feeling better and more hopeful. 喐動幅度大啲，關節比以前靈活。肌肉有咗力，好少病，精神好咗，亦都大力咗。And then when we hear about 大力咗 he's talking about 舉起手提電話。So you can see that actually this girl actually is very, very severe in his motor weakness to start with. 最後呢位家長 I really like this. He said 雖然喺行動能力嘅改變係冇咁大，但係喺呼吸方面實在改善咗好多。而家可以計劃帶佢去迪士尼樂園玩。And I think this is really encouraging because they are hopeful to do something that most people, would take it for granted. Nothing think is a big thing, but for them actually is a challenge. And now they're able to do it. So family functioning and health-related quality of life of both patient and parents can be improved after treatment. And we find self-reported questionnaire actually allow us to understand better in what way the treatment has helped each patient and family. More stable health, better independency in daily activities, and less care burden are all contributing factors. Next, I'd like to mention about some of these biomarkers that people has been reported. They said the neurofilament is a very helpful marker to measure the response in children with SMA treated with nusinersen. So in this paper that is published in the Journal of Neurology, you can see all those patients receiving nusinersen, and after about 4 to 5 doses, they have marked decrease in the neurofilament. And neurofilament is actually a marker of neuronal damage. So because I see this paper, I find it will be important to see what actually is the finding in our group of patients. So I sent off some of the samples CSF samples of our patient with 7 SMA type 1 and 5 SMA type 2 and 3 SMA type 3. You can see the green color are all those SMA type 1 from very young, less than 1 year, to up to 24 years old. You can see all of them actually have the highest neurofilament baseline level, but marked decrease after the 4th to 6th dose of treatment. For the SMA type 2, which is in orange, again, they have the decrement of the neurofilament level after the treatment. They have a less baseline, but again, you see a decrement, significant decrement level. And we have one patient with SMA type 3, again, showed the same trend. So we know that the treatment actually is decreasing the neuronal damage and the further deterioration of the anterior horn cells, lesions and stabilization. That's why we see the improvement. So what's the way forward? I spend the time to share the detail with you because I think the next stage, with now an established good treatment program, is about the newborn screening, because there are so many evidence that I do not have the time to share with you at this talk today to show that the earlier the treatment, the better. When we talk about the newborn screening, the condition must be a significant and severe health problem, which SMA is definitely no doubt one of them. We need to have a recognizable latent stage, means a pre-symptomatic stage that is being able to identify. The natural history must be well known, like SMA. We all know about the SMA type 1, 2, 3, and also available screening and diagnostic tests. Now, with the approved treatment also available and demonstrable benefit of early detection, intervention, and treatment, I guess newborn screening is the way forward. And in fact, around the world, there are a number of countries is advocating the newborn screening, like in Taiwan, in many states of the United States, and also in many countries in Europe. So a few messages I'd like to share at the end of my presentation. SMA is a medically complex disease with progressive disease course for all types. Currently, we have FDA-approved therapies for SMA, and they are available in Hong Kong. There is also increased evidence on effectiveness of FDA-approved treatment for both pediatric and adult onset SMA patients. Implementation of standard of care is essential for all SMA patients, be it they are accessible to SMN modifying therapies or not. The teams need to work together to learn the new natural history for those receiving new therapies. And transition of care to take care of patients across lifespan is also important to advocate. Last but not least, SMA newborn screening, the preparation is underway, and I sincerely hope all will support the team that is involved in this to help this group of patients, because it will make a big difference to the child's life, to the family, and also improve the healthcare costs. With this, I hope everyone on earth with SMA, everyone in Hong Kong with SMA will eventually be able to get access to the treatment. Last, I just want to thank all the team in the HAHO, in Queen Mary, Hong Kong Stage team, and especially my SMA treatment team and the genetic team, and all the COS in a different department, different department pediatric in different HA hospital, as well as our close pediatric neurology colleagues in all the HA hospital. And I especially like to thank my overseas team, Professor Jung and Professor Darius, for the advice when I help the team to set up the program. Thank you so much for the attention.
Sophelia Chan 咧為我哋好詳盡解釋咧，同埋咧介紹咧最新嘅醫治 SMA 嘅方案同埋方法啦。咁亦都咧好多好令人鼓舞性嘅個案同我哋分享。咁咧呢度咧有幾個問題啦，咁咧就想問多 Chan 嘅。咁第一個問題咧就係when will the oral medication available in HA? When this is available, will all the patients on IT nusinersen gradually change to using these oral medications?
我呢個可以用中文代答啦。
可以。
咁個 oral Ritalin 咧，其實已經 approach 咗 HAHO， 咁其實亦都會喺短時間內，我哋會有一個好似啲 compassionate use 嘅 program。咁但係 compassionate use 嘅 program 咧，都會係俾最 severe 嘅 SMA type。咁呢個係一定係 prioritize to SMA type 1 and maybe some SMA type 2。咁因為佢係 oral 咧，所以嗰啲如果個 intrathecal 頭先你見到個好 severe scoliosis 好困難咧，佢哋會有一個 priority 可以去轉去選擇用一個 oral route 嘅嚇。
好。咁第二條問題咧就話：請問 gene screening 係咪會阻止SMA 遺傳落去嘅可行方法？即係呢個係咪一個可以阻止呢種 SMA 遺傳落去嘅可行方法？
我諗因為如果我哋講緊 gene screening 咧，我哋可以講緊係 newborn 嘅 screening 啦，但係 newborn 嘅 screening 咧就係 diagnosis。我哋亦都可以講嘅係 carrier 嘅 gene screening， 因為我哋其實知道個 carrier rate 咧係好高。咁如果個 couple 係佢哋準備想有 plan for 個 pregnancy 嘅，想 start 個 family， 咁而家咧都有啲屋企人佢哋自己會可能其中一個去 test 咗，如果其中一個係 carrier 嘅，咁可能就 advocate 另外一個都 check 埋個 carrier，甚至考慮去做一個 prenatal。如果真係兩個都 carrier 嘅時候，就好需要去傾需唔需要做呢個 prenatal diagnosis 啦，或者係會 strongly encourage 佢去做呢個 prenatal diagnosis after discussion 啦。因為我哋知道佢有 25% 嘅 chance 咧，呢個 baby 係可以 being affected 嘅。
想 follow 問翻個 antenatal diagnosis 咧，喺香港而家嘅情況係點樣樣？
我知道其實香港嘅 antenatal diagnosis 咧都做得好好嘅。咁我哋知道有譬如好似 clinical genetic service 啦，咁我亦都知道瑪麗佢哋個 antenatal 嘅 team， 佢哋自己都有refer 一啲有啲 patient being referred to them to do the antenatal diagnosis。咁一啲好 severe 嘅 disease， 如果真係佢想 prevent 佢 occur 嘅，另外一個會唔會有啲人會傾佢哋PGD 咁，好似做一個即係種植中文點樣講咧？即係 pre-implantation 嘅 genetic diagnosis 咧，即係然之後先至 implant 翻落去，係有嗰啲 uninvolved 即係 unaffected 嘅 embryo。So there are different options 由個真係個 antenatal 去到 chorioamniocentesis choriocentesis 或者係 amniocentesis 咁呢啲因為都 involve 一啲 invasive procedure 啦，咁會唔會有個 risk to 個媽咪或者個 embryo 啦？咁呢啲都一定要有嗰個 specialist who's doing it 去 explain to 佢哋。係啊。
好。咁另外一條咧就係想問咧，嗰隻 oral medication 可唔可以 provide to adult type 3嘅 patient，SMA 嘅 patient？
而家咧，其實我都見到咧，最近咧都有講問關於其實有冇啲 drug 可以 available to 個adult 嘅 SMA patient。咁so far 咧就睇翻過往嘅 paper 咧，就我哋見到咧陸陸續續咧個 evidence 咧係越嚟越多嘅。咁亦都傾向咧，因為個 number of 個 participant 或者個 patient 喺個 study 度咧係越嚟越大，咁所以見到嗰個 gain 咧，其實係由以前嘅冇咁 significant 咧，至到而家咧係明顯咗嘅。咁至於 oral 嗰隻藥咧，好方便啦。但係咧雖然 FDA approved 咗，但係其實佢個 publication 咧，如果大家去 PubMed 嗰度睇咧，你係唔會未揾到，因為佢都仲未 get published。So I guess actually is on the way 咁我相信佢 FDA approved 一定有好多嘅 evidence 同數據啦。咁我亦都知道，因為Ritalin 係喺 China 咧有做呢個 clinical trial。咁我睇過有啲case sharing from 我喺 China 嘅 collaborator 咧，特別係啲 SMA type 1咧，都係 encouraging 嘅咁所以 I think it's really helping。
好，咁另外有一條問題咧，就係話 really glad to see that they are given a new lease of life. Is there any advice for them on having children in the future?
喺外國呢個問題咧，一定會經常出現啦。咁我覺得我 so far 咧，我咁耐咧認識咧，就係有一個 adult 嘅 SMA Type 3，佢真係有個 family 嘅。我覺得我哋記得有一個 function，我哋邀請咗佢過嚟 share， 咁係好鼓舞佢太太同埋佢個小朋友一齊嚟。咁我覺得 if the health is good，and then 佢有一個 life and medically is good for him or her, actually it is actually 係個 medical team 應該去點樣諗，去幫佢 make sure 佢 is a safe journey and is manageable、and it's possible I think、but of course is 都要睇佢個健康啦，同埋佢生咗 BB 之後佢又會多好多嘢做，又要好多嘢要照顧嘅the new members of the family， 咁個 family support 都好緊要啦。
好，另外一條咧就係、When will be the best time to screen for SMA in newborn? Can it be incorporated with IEM screening?
我覺得香港真係好 lucky， 因為咧我哋前期有好好嘅 IEM team， 佢哋 set up 咗一個 amazing job， 就係佢而家可以 establish that collect all the newborns from 所有嘅 XH hospital 去到做呢一個 newborn screening， 因為呢個 system 咧，呢個 infrastructure 係好緊要。When is the time to do it？ 我成日都講 as early as possible， 因為你做咗個 newborn screening 之後咧，佢要做 genetic screening 之後咧，佢要再 cross check。咁所以 for 我哋喺 Camp Path 嘅同事，佢哋要 try to 同時間比賽，咁然之後最快攞到個 result。但係攞到個 result 之後唔係咁容易就完咗個噃，因為又要 check 個 SMN2 number 啦，咁亦都要解釋俾屋企人聽啦。咁同埋咧要個 team 去 prepare 個 treatment。但係而家我最近去譬如法國Belgium， 佢哋係競賽嘅。Once they get the result, they will do it no matter how late is the date、to give the treatment. Because as long as the child is asymptomatic， 佢咧就即係 you know is like the best salvage like minimum damage has occurred。
你頭先都 mention 過係3個月前，即係如果譬如佢係出世之後3個月內俾咧，嗰啲 result 係最好噶嘛？頭先我記得你喺張 slide 講過。咁譬如呢一個咁嘅 process 要幾耐到咧？即係譬如佢 newborn screening screen 到啦，跟住你仲要睇下佢有幾多個 SMN2 copies。呢個成個過程大約要幾耐咧？你估計
？I may not be the best person to answer，因為我諗我哋嘅 genetic 同事我哋嘅 geneticist 或者佢哋嘅 scientist 同埋 Camp Path 嘅同事 who's doing it。但係我過往淨係講 diagnosis。如果我哋講嘅 diagnosis 一個 SMN1 gene mutation with the SMN2，actually the diagnosis can come back within a week，or less than a week。咁所以我相信係可以做得好嘅，我哋嘅團隊。
好啊，好咁有一條係講關於錢嘅問題啦。What's the cost of this oral medication as compared to nusinersen for treating the same patient？
OK， 呢個咧就又去到啲商業秘密啦。咁啲商業秘密咧，即係我唔知道個真正嘅 number。In fact， 如果你去上網去睇咧，they have that open up available。係一個英鎊咁樣on the internet for public 嘅。咁佢係平過我上去睇 same as nusinersen 咧喺個 internet 度咧，我計個 conversion from US 咧係差唔多600幾萬。That what I know actually for different country they will actually has a different list price after negotiation 咁我相信我哋嘅 HAHO 或者 Central Pharmacy Offices 係會好清楚啦。咁我知道係平過嘅。咁我諗佢有佢個 advantage 咯。咁因為佢平過啦，同埋 oral route， 咁所以對個 treatment team 同埋對個 patient 咧，佢都會係more convenient 同埋 less invasive。
好，咁有位同事咧想問 ，Can you enlighten us more about newborn screening? What's the method or test used in Hong Kong？
我都係I must declare I'm not the best person to do it. To answer this question， 因為到最後真係做咧，會係我哋嘅 campus 同事同埋我哋嘅 geneticists 一齊。咁但係我知道有好多 established 嘅 method 啦，例如係啲 qPCR and the other DT-PCR and also the MLPA to test it. So 呢啲都係一啲好 established 嘅 method 啦。咁同埋我哋有好多外國已經 established 咗 newborn screening for some times 嘅 experience， 我哋可以借鏡。So I think 呢個我留翻俾專家，遲啲即係俾一個最準嘅答案啦。
好，仲有一條問題咧，就問 any difference in intravenous or intrathecal medication？
而家咧intrathecal 咧， so we have to give it into the CSF space. So nusinersen must be given intrathecally. So 佢可以直接咧就喺個 central nervous system circulate. Intravenously 咧 ，only the gene therapy 喺好細嘅小朋友咧 ，they are testing to be given intravenously. 咁佢個分別就係佢會 circulate around the whole body instead of only to the central nervous system。咁佢亦都要 guarantee 佢如果用 AAV9， 因為 gene therapy 佢用 AAV9 咧 ，that viral vector as a carrier can actually cross the blood-brain barrier。咁所以亦都佢有提到一個 advantage 就係佢 not only treat the central nervous system， 佢亦都 treat all the other organs that is being affected by 個 deficient of the SMN protein。咁risdiplam 就係 by oral 啦，so is another route of drug delivery。
OK， 咁又有一條問題咧就好 practical 嘅，問 Do you always give nusinersen in the operating theatre or in ICU? Do you give sedation?
So drug delivery 睇瑪麗醫院就一個團隊啦。如果個 patient 係冇 major scoliosis or only very mild, we can do it actually in the treatment room of a general ward. And in fact, we have one patient 係 SMA Type 3，因為唔可以去外國做個 treatment， 咁我哋嚟咗兒童醫院嗰度 treatment。咁我哋都試過咧，有兩個做法。第一個兩個都係 day procedure， 就係入咗 operating theatre， 因為好好呢度 anaesthetist 可以 support 啦，咁佢即日就可以走得。第二個咧，我哋最近一次都係其實喺個我哋個 ward 度嘅 treatment room 咁俾。咁至於嗰啲 patient 如果要 on NIV，which is already on ventilator，be it 係 nocturnal 或者係24 hours 或者係 more than 16 hours 嘅，我哋都會收佢入去 ICU 啦。咁喺瑪麗我哋 ICU team 嘅同事好好，都會幫手。咁我覺得係一個好似 high DU 咁嘅 care。They are actually stable when they enter that。咁當佢 under sedation 嘅時候咧，佢大部分我哋都會用 sedation 嘅，尤其是唔可以 cooperate 或者我哋想去 pain free。咁佢哋可以 monitor under the sedation。咁 so far 咧就most of the experience they are very very smooth。咁我哋亦都有 patient 咧 opt 自己 opt for 淨係用 LA， 唔需要俾 systemic sedation。咁通常佢哋係大個啲啦，同埋 can tolerate pain and 即係 prevent themselves from moving 嚇，因為個 procedure 都要佢好定，咁先至可以個 portal of entry 咧就唔會咁容易 traumatize 到佢。
OK， 好可能呢條係最後一條問題啦。Will you view SMA not just a neuromuscular disease now?
From a pathology point of view, SMA is a neuromuscular disease. But from a whole patient care perspective, SMA is not just a neuromuscular disease. They are like every one of us. They have a life, but they have that medical challenge that actually need to be weighed more braver than any one of us to walk along the path. 咁我覺得好開心，就係咧每次我見到佢哋咧，好即係啲屋企人咧真係見到好開心。就算一啲嘅 improvement 做到一啲佢哋以前做唔到嘅嘢咧，佢哋嗰種笑容咧，同埋嗰種開心咧係會令到我哋真係好 inspire， 因為 it's so truthful and it's so important for them. And then it makes me realize actually these are the things that is important in life.
好多謝陳醫生嘅解答。咁可唔可以容許我咧都問一條最後嘅問題？而家我哋有一隻 oral 嘅drug 啦，可以俾啲病人。咁頭先你提到，如果係俾 nusinersen， 我哋可以 check 佢 CSF 個 biomarker neurofilament。咁但係如果我哋第日用 oral medication， 我哋有冇一啲簡單啲，即係可以 check 血嘅 biomarkers 嚟 monitor 咧
？In fact neurofilament 咧都可以抽血㗎。So they can check CSF and blood. I just send for the CSF because I think it's more direct. The other thing is I can use less of my research funding. So and equally I see very nice and important result. Yeah.
OK， 好多謝你。咁咧，我諗我而家咧就代表香港兒童醫院咧，致上呢個好精美嘅紀念品俾 Dr. Sophelia。多謝晒。
咁咧好多謝 Sophie， 好多謝阿衛蘭。哇，今日好精彩，我覺得。咁咧有啲畫面咧，大家睇唔到嘅。咁咧就係我哋喺 run this slide 嗰陣時，即係未開始講嗰陣時候咧，其實就同阿 Sophie 一齊 run this slide。咁咧就我見到個畫面，我諗我呢世都記住。佢望住嗰啲video 咧，佢會笑喎。即係我諗佢睇過呢啲 video， 我諗睇過幾百次。但係咧，佢望住嗰啲 video， 啲細路仔吹波嘅，我頭先都笑啊嚇！即係佢哋行到咧，佢好開心。咁同埋頭先我哋個導演冇影啊 Sophie 嘅大頭啦嚇。咁咧佢有啲畫面咧，佢真係我覺得佢真係好感動啊，好感恩。咁即係我覺得一個好醫生咧，就永遠都係由個病人嗰個出發。咁我諗 Sophie 真係一個非常非常之好嘅醫生嚟嚇。咁唔止係好醫生啦，仲有一個好嘅 scientist 啦嚇。即係幫我哋即係一個我都冇諗過咧 SMA 會有得 improve。我又有少少做緊 palliative care 啦。咁咧就只會話俾屋企聽一出世 diagnose 到就不如我哋早啲 plan palliative care 啦咁樣。咁我諗而家真係我哋可以諗下，我哋可以點樣 improve 佢 quality of life。咁頭先講得好好嘅，最後尾個問題我都真係問得好好嘅，係咪 neuromuscular disease 咧？其實冇個 disease 真係個 disease 嘅，個 disease 咧真係要好多人一齊幫手一齊 manage 嘅。頭先咧我寫低咗幾個字啦，有3個 patient 佢覺得 quality of life 咧係差咗，因為冇得返學。咁我覺得即係醫社教啦，我哋成日話學校真係好緊要，即係俾個小朋友同埋家長覺得即係生活係正常。咁所以我諗我哋希望都 involve 學校啦嚇，即係佢哋 understand 多啲小朋友咧，就唔會下下就擁佢入嚟醫院度啦。呢個第一樣。嗱，第二個咧我嘅經歷喺啲 special school 咧。同埋啲屋企人咧，佢哋其實好想翻屋企。首先我哋話佢住 ICU 咗幾個星期，後尾佢住1個星期，好開心。我亦都訪問過一個 SMA 嘅小朋友嘅家長，咁嗰陣時我哋傾緊話，有啲 donor 話想整個 palliative care 嘅 cubicle 咁樣。哇！佢嘅反應好大，佢話陳醫生，你做咩整個 ward 俾我啫？我想翻屋企嘅，其實你不如幫我整架車啦。我可以車小朋友翻屋企，車小朋友周圍去。咁 home care 喺香港咧，其實真係好 deficient。咁我希望大家即係SM 係一個例子啦。其實好多小朋友咧都要翻屋企，我哋可唔可以咧即係盡量 enable 佢翻屋企啊？因為喺醫院咧，無論兒童醫院又好咩醫院，一流嘅醫院都好啦，都係唔似屋企嚇。咁當然要好多 support 啦咁樣。咁今日好 inspire。咁啊，仲有一個小插曲係咩咧？其實咧今日好 technologically challenging 嘅嚇。我哋未試過咧咁問先收到個 PowerPoint，而個 PowerPoint 咧入邊係咁多 video。咁咧就其實好難播呢啲 video。就好在我哋幾個禮拜之前咧又用咗個新嘅 technology。 咁咧就變咗今日大家我頭先監察住個 Zoom 咧都好流暢啊咁樣。第二樣嘢咧，其實阿 Sophia 好有心嘅，因為咧佢其實咧好多段咧佢啲音樂嘅。不過頭先有一個觀眾話啊，不如你可唔可以停咗啲音樂啊？因為 Sophia 把聲其實好聽嘅，佢講得。咁我又覺得我都同意佢，所以我就瞄咗聲。咁我當佢 Sophia 即係致歉先嚇。所以雖然擺咗好多心機落去嗰啲音樂嗰度，咁我哋又即係因為啲聽眾嘅 feedback， 我哋就咩？咁其實我哋中意啲 challenges 嘅。咁所以咧就如果將來即係有多啲 challenging 啲嘅 presentation 咧，我哋都想試下嘅嚇。咁但係呢個係好開心啊，今日嚇非常非常之開心。咁就我希望遲啲又再揾阿 Sophie 上嚟講下啲新嘅 advances 啦嚇。咁尤其是 Antenatal Diagnosis， 因為的確有啲產科醫生都問我哋嚇，咁究竟可以點樣做咧咁樣樣。好，咁今日就都好多謝 Sophie， 咁衛蘭就係啦嚇，即係幫我moderate 呢個 talk， 咁好多謝你哋兩位，好多謝晒，咁多謝大家收聽嚇，好，拜拜。